My name is Ashton Smith, a PA student with the Duke Physician Assistant Program. Thank you for joining me as I present Y90 radioembolization, a treatment modality in interventional radiology. Y90 as a treatment is a catheter-based procedure. We use the radial or femoral artery that allows us to selectively introduce radioactive microspheres to liver tumor tissue. It's important to note that these kind of malignancies derive the vast majority of their blood supply from the hepatic artery rather than the portal circulation. And so being able to selectively administer radiation is preferential, not only because it delivers targeted therapy, but also spares normal liver tissue more than other procedures. We utilize it a lot in interventional radiology for patients with hepatocellular carcinoma, or HCC, which is where I will focus today, but also can be used in patients with neuroendocrine tumor that have hepatic mets and patients with hepatic mets from colorectal cancer. It can be used to downstage if a patient is looking to meet the MELD criteria for transplant, but it's primarily used as a modality in patients with advanced staged HCC for whom resection and transplant are no longer options. Looking at epidemiology, HCC is the sixth most common malignancy worldwide and the third most common cause of cancer-related mortality, with a 5-year survival rate of just 18%. It's often diagnosed in advanced stages where resection and transplant aren't options anymore, and sadly this is the case in up to 77% of these patients. And there is a male to female ratio of 3:1, meaning males are affected more. In terms of pathophysiology, the major risk factor is cirrhosis. Most, if not all, of these patients do have cirrhosis. Also, hepatitis virus, male sex, age, so a younger age when they contract hepatitis B, or an older individual with chronic hepatitis infection are at greater risk. Lifestyle factors like smoking and alcohol consumption, and metabolic factors like non-alcoholic fatty liver disease, obesity, and diabetes. There really is a broad spectrum of how HCC patients will present clinically, and that's because you have to consider the stage in which they're presenting. Patients who are in a really advanced stage often present more with symptoms of the underlying cirrhosis rather than HCC itself, and these are things like jaundice, scleral icterus, itching, etc. You'll see, though, in patients across the board with advanced HCC lesions, some of the things on this list below. Weight loss, early satiety, you can see hypoglycemia because the tumor itself has an increased metabolic demand. Diarrhea from electrolyte abnormalities and lab abnormalities that can include a serum AFP elevation, hypercalcemia, and erythrocytosis. Diagnostic workup is going to involve MRI or CT imaging with and without contrast to be able to get the LIRADS score. LIRADS is a category that reflects probability of HCC and is based on typical CT and MRI findings. Of note, patients that are candidates for Y90 are typically LIRADS 5, sometimes LIRADS 4. These patients are known to have cirrhosis, so typically they're already receiving scans about every 6 months just to look for HCC. Sometimes a biopsy is needed, and this might be in cases when the diagnosis is in question between HCC and a different type of cancer. However, this is one of the few cancers you can diagnose solely based on imaging versus biopsy, and that can happen up to 95% of the time. So, assessment and plan. We review the imaging. Are the arteries patent? Are there multiple lesions? Because if there's just one, maybe ablation's a better option. We look at the ECOG score, which is really important because it evaluates the patient's ability to care for themselves on a day-to-day basis in context of their disease. And then the ALBI score is a huge takeaway for me, and I hope for you too. So in this case, the ALT and AST that we're so conditioned to looking at are not what we look at to determine if a patient's liver is functioning well. We are looking at albumin and bilirubin because we know this procedure will damage some degree of non-liver tissue. We need to know how well the liver is absorbing nutrients and breaking things down, and so this score reflects how well the non-tumor hepatocytes can withstand the effects of this procedure. Y90 treatment is a multi-phase treatment, and so phase 1 is the planning phase, and this is really where we have our roadmap. We use the radial or femoral vein to thread a catheter down through the hepatic artery to that tumor itself. We do arteriography, and importantly, that allows us to identify vascular abnormalities, but also the exact branches feeding the tumors. Cone beam CT is done to get lobe volumes, and this helps us make an exact radiation dose for the patient should they proceed with the treatment phase. Coil embolization can be used if we're worried about reflux into collateral arteries, and from there we deliver a radiation test dose and send the patient to nuclear scan. The purpose there is to make sure that we don't see excessive hepatopulmonary shunting or reflux into arteries that supply the gastroduodenal regions, because if these things happen, then we look at serious morbid complications like radiation pneumonitis and gastric ulceration. And this is an outpatient procedure. These are just two very cool photographic examples that I did take with the physician's permission while they were doing this procedure to show you how useful this arteriography is. You can see how specific this gets down to that circle target area so that we know exactly which branches we want to deliver that radiation through. When all goes well in that planning or mapping phase, we proceed to phase 2, the treatment phase, about a week or two after we've done the planning phase. Again, we get radial or femoral access, and this time a tumor-specific dose of radiation is delivered via the hepatic artery in the form of Y90 microspheres. These have a 1 centimeter distribution, which means that those patients do not need to leave worried about being radioactive to those around them, as this is another outpatient procedure. Outcomes are measured with post-procedure imaging. That time can vary a little between providers, but is no sooner than 4 weeks. Outcomes are measured in terms of clinical benefit, complete resolution, partial resolution, stable disease, and progressive disease. If you look at A and C below, A shows a large mass in the liver that is taking up a lot of contrast with active blood supply. The after procedure is image C, where you see very little contrast uptake and a lot of tumor necrosis, which is a good outcome. When I looked at the literature, it seemed important to me to look at radioembolization versus chemoembolization. These studies are limited, but they are in favor of radioembolization in several ways. They say that there is a superior palliative role in RE, and that's by increasing tumor necrosis and delaying the progression of the disease. In the few studies that I was able to find information on, the radioembolization arm actually tended to have patients that were doing worse overall, and those were patients with more advanced disease, larger tumor burden, and you would think that that would reflect better on the chemo end of the study, but actually that was not the case, and radioembolization was still less of a treatment burden overall. Patients who had radioembolization had a shorter hospital stay with a mean difference of 2.66 days, largely because it's an outpatient procedure, whereas chemoembolization in 60 to 80% requires 2 days, 2 nights in the hospital. And overall survival was greater in the radioembolization arm with 39 months versus 31 months for chemoembolization. 61% of radioembolization patients achieved partial resolution versus 37 in chemoembolization, and there was a more effective downstaging in patients from UNOS T3 to T2, which could be important in those that are headed towards liver transplant. Sadly, the field of hepatology really isn't any different than other fields of medicine where we see so many problems with inequity from social determinants of health. They're closely linked to disparities in liver disease prevalence, outcomes, and access to treatment, which is not unfamiliar to hear. This model shows us that upstream determinants lead to different exposures to the midstream factors and detrimental health outcomes on the downstream end, creating disparity. We can see here that COVID-19 is adding impact on what's already an existing disparity. For example, a low-income person with non-alcoholic fatty liver disease may be living with greater food insecurity during the pandemic and thus have a harder time, making the specifics of that dietary regulation that's been given to them. And so it's recommended that we partner with food banks and other community organizations to improve diet quality for patients like this, and just to improve education out there that these conditions do exist. So what do we do to tackle these disparities? We recognize that it's racism and implicit bias that's causing and perpetuating them. We start by reflecting on our own overt and implicit biases, and then from there we promote implicit bias training to those around us. And there we develop strategies to ensure inclusion of diverse members into educational activities and leadership roles so that those opportunities to connect are really there for our patients. This is my list of references, and I would like to thank you once again for joining me as I talk about Y90, and please reach out to me with questions. Thank you.